Welcome to the debate. Usually when modern medicine fights an infection, we can actually see the battlefield. Like if you suspect strep throat, you take a swab, you culture the bacteria, and there you go. You have your answer.
Right, it's visible and it's measurable.
Exactly.
And that provides a really comforting level of diagnostic certainty. I mean, as clinicians, we like our pathogens neatly identified and categorized, right before we deploy our treatments.
Oh, absolutely. But today, we're talking about a totally different anatomical landscape. When you look at the human skull, specifically the frontal sinuses, that empirical window completely vanishes.
Yeah, it really does.
You are no longer looking at a visible surface. You are essentially staring at a sealed box of bone. And when a patient presents in urgent care with blinding forehead pain, you cannot simply look inside.
It is the clinical equivalent of a locked, dark room. A violent inflammatory process is happening in there because the patient is in absolute agony, but you cannot directly see the pathogen causing it.
And that biological blind spot is the foundation of our discussion today. We are examining a critical shift in how we treat recurrent frontal sinusitis in urgent care settings.
Specifically, we're looking at the 2026 medical protocols, right?
Yes. The protocols that aggressively move away from laboratory testing and that traditional 10-day watchful waiting period. They're shifting in favor of rapid, symptom-based clinical diagnoses.
So the central question we are exploring is this. Is it clinically responsible and necessary to aggressively treat recurrent frontal sinusitis with antibiotics early at just 3 to 4 days, based purely on subjective, severe clinical symptoms to prevent neurological spread?
Right. Or, conversely, does bypassing objective lab evidence and traditional waiting periods invite dangerous overprescription? Does it risk ignoring the true nature of the inflammation?
Exactly. And to be clear, this debate emerges directly from the 2026 Urgent Care Guidelines, the MIPS, that's the Merit-Based Incentive Payment System Quality Measures, and the IDSA protocols.
The Infectious Diseases Society of America, yeah. And their protocol surrounding acute on chronic or recurrent frontal sinusitis.
Right.
I argue that relying on real-time, severe clinical symptom progression to initiate early antibiotic therapy at day 4 is a necessary, common-sense evolution that protects patients from dangerous systemic spread.
And I contend bypassing the 10-day watchful waiting period based on subjective pain markers, which, as we'll discuss, often mimic deeper infections through mere nerve irritation, risks unnecessary exposure to high-potency antibiotics and accelerates systemic resistance.
So to set the foundation from my perspective, I think we have to acknowledge that in an urgent care setting, objective laboratory tests are practically useless for sinus infections.
Well, they're definitely limited.
Very limited. I mentioned the sealed box problem earlier. If you take a throat culture, it only tells us what flora is sitting on the surface of the throat. It absolutely cannot see the bacteria trapped behind the forehead bone.
Oh, I agree that throat cultures lack the anatomical reach. And imaging, like a CT scan, is rarely practical or, even available in a standard urgent care setting.
Exactly. And blood cultures present what we call a snapshot problem. They only catch late-stage infection. If a pathogen has breached the sinus cavity and entered the bloodstream, well, by the time a blood culture is positive for sepsis, the patient belongs in the ER.
Not urgent care.
Right, not urgent care. So, we are left with clinical presentation. The frontal sinuses sit mere millimeters from the brain. Therefore, when a patient presents with severe symptoms like a high fever, chills, and purulent nasal discharge over 3 to 4 consecutive days, that provides a far more accurate, real-time map of the infection's progression than any delayed lab test.
A real-time map, huh?
Yes, and that clinical map absolutely justifies skipping the outdated 10-day waiting rule. We need to prescribe targeted treatments like high-dose Augmentin when we see those signs.
I come at it from a very different way. I do not deny that frontal sinus pain is agonizing for the patient. I mean, if you're an urgent care provider listening to this, you know exactly the type of patient we're talking about.
Mm-hmm. The ones in absolute misery.
Right, they walk in terrified that the infection has reached their brain. But as clinicians, we really must maintain rigorous definitional precision between true bacterial infection and localized inflammation.
But let me just finish this thought. The subjective experience of pain is simply not a reliable proxy for bacterial load.
But when that pain is paired with a specific progression of symptoms, it is no longer just subjective. The 2026 protocols explicitly authorize immediate antibiotic therapy if a patient experiences 3 to 4 consecutive days of a high fever.
High being 102 degrees Fahrenheit, right? Yes, 102 degrees Fahrenheit or 39 degrees Celsius, coupled with severe frontal pain. I see why you think relying on symptoms is inherently subjective, but let me give you a different perspective. Consider the biological phenomenon of double sickening.
You mean the biphasic illness pattern?
Precisely. A patient gets a viral cold, they feel a bit better for a day or two, and then suddenly, boom, they are hit twice as hard with a spike in fever and intense localized pain.
Right, the secondary phase.
Yes, and what is happening mechanically is that the initial virus has stripped the protective mucosal lining of the sinus. The microscopic hairs, the cilia, that usually sweep out debris, they are paralyzed. Okay, that is a compelling argument. But have you considered what those symptoms actually represent at a systemic level?
What do you mean?
Well, you are pointing to a high fever of 102 degrees, the chills, and the body aches as definitive proof of a multiplying bacterial army that just must be eradicated immediately with an antibiotic.
Because it usually is.
But if we look at the physiology, those symptoms simply indicate that the immune system has released a massive storm of cytokines into the bloodstream.
And a cytokine storm is exactly why the patient feels so terrible. Right. But what is a cytokine? It is a chemical messenger. When tissue is damaged, whether by a virus or bacteria, macrophages release interleukins. These travel to your hypothalamus, your brain's thermostat, and intentionally shift your body's temperature set point upward.
To create an inhospitable environment for pathogens, yes?
Exactly. And that sudden shift is what causes the violent chills and muscle aches. It means the body's immune system is doing its job fighting an intense localized battle, sure, but it does not necessarily mean you have a bloodstream infection or an unmanageable bacterial load.
I think you're underestimating the risk.
I just think that treating based on a 4-day fever is often treating the fear of an infection spreading rather than relying on measurable bacterial presence.
Well, I'm not convinced by that line of reasoning because it treats a frontal sinus infection as if it carries the same risk profile as, like, a scraped knee. The anatomy of the situation demands a higher level of urgency.
Which brings us to the actual sensation of pain, which is the primary driver for abandoning the 10-day rule in these protocols. We really must interrogate the biological reality of what the patient is actually feeling in that moment.
The agony.
Yes, the agony. The 2026 literature uses the term frontal sinus cephalgia. Patients present in urgent care absolutely panicked. They report phantasmia,
Which is a distorted sense of smell. They usually describe smelling something burning or metallic, right?
Exactly. They get this phantasmia along with severe brain fog and a headache that feels like it has enveloped their entire skull. They truly believe their brain is infected.
Because it feels like it is.
But the text clearly establishes this is trigeminal olfactory crosstalk. Let's break down how that works. The olfactory neurons, the smell cells, right at the ceiling of the nose, are essentially dangling naked in the nasal cavity.
Right.
So, during a severe sinus event, inflammatory byproducts like histamine and bradykinin literally bathe these neurons. They are being chemically burned.
Which again is agonizing for the patient.
It is. And those chemically irritated neurons send frantic danger signals up through the olfactory bulb. But because the trigeminal nerve, which handles all the pain sensation for the face and head, is sitting right next door, those signals cross over.
The crosstalk.
Right. The brain misinterprets this localized chemical burning as a massive whole head trauma. It feels like the brain is under attack, but the cribriform plate, the thin bone separating the nasal cavity from the brain, has not been breached.
Is fire to dictate a panicked pharmacological response.
I think minimizing the anatomical reality of that nerve pain is incredibly dangerous. I really do.
I'm not minimizing it. I'm explaining the mechanism.
But look at it this way. If the cribriform plate is a structurally compromised retaining wall holding back a flood from destroying a city, You don't wait to see if the wall completely collapses before you start sandbagging.
Well-
You act when you see water seeping through the cracks. The frontal sinus is literally millimeters away from the eyes and the frontal lobe of the brain. Common sense dictates that the closer an infection is to a vital organ, the more aggressive the treatment must be to prevent a catastrophe.
But is it a catastrophe or just nerve pain?
I agree. It's systemic inflammation.
The immune system is waving a red flag, and ignoring that flag to satisfy a rigid 10-day waiting period puts the patient at risk for severe orbital or neurological complications.
I agree that the proximity to the brain is what dictates this perceived urgency, but if this is truly just nerve inflammation, as I am arguing, then this inevitably leads us to a clash over the specific pharmacological weapons urgent care providers are choosing to deploy in 2026.
The antibiotics.
Yes, because the moment we declare that a four-day headache constitutes an impending neurological crisis, we open the door to extreme antibiotic escalation.
And I defend that updated antibiotic hierarchy because it is tailored to the biological reality of recurrent infections. High-dose Augmentin is appropriately established as the gold standard, the first-line defense for acute bacterial rhinosinusitis, or ABRS.
But is high dose always necessary?
Yes, to overcome resistance. Why? Because the clavulanate in the Augmentin specifically acts as a suicide inhibitor. Bacteria develop resistance by producing an enzyme called beta-lactamase, which shreds standard penicillin.
Right, it neutralizes it.
Exactly. The clavulanate sacrifices itself, binding to that enzyme, which allows the amoxicillin to actually destroy the bacterial cell wall. Furthermore, the guidelines highlight doxycycline as an excellent alternative.
Mostly for patients with penicillin allergies, historically.
True, but also because of its precise mechanisms. Doxycycline possesses secondary anti-inflammatory properties. On a cellular level, it inhibits matrix metalloproteinases.
The enzymes that break down tissue.
Right, the enzymes that break down structural tissue during high inflammation. By inhibiting those, doxycycline specifically reduces the exact nerve inflammation, that trigeminal olfactory crosstalk that you are so concerned about. We are treating the bacteria and calming the nerves simultaneously.
I'm sorry, but I just don't buy that justification.
Why not?
Let me tell you why. If the guidelines stopped at Augmentin and doxycycline, we might have a narrower disagreement. But the 2026 protocols also normalize deploying heavy artillery for recurrent cases, specifically what is known as the plus strategy.
Oh, the dual therapy approach?
Yes. Providers in urgent care are now pairing clindamycin with cefixime to hunt down hidden anaerobic bacteria,
Which survive in the scarred tissue of recurrent patients. It makes sense.
Let's look at the pharmacology of that escalation. Clindamycin disrupts bacterial protein synthesis, but by itself it is notoriously weak against Haemophilus influenza, one of the most common sinus pathogens.
Which is why they pair it.
Right, because H. flu is gram-negative, its outer membrane blocks the clindamycin from entering. That is why the guidelines force providers to pair it with a second broad-spectrum agent like cefixime. But here is the critical danger. Clindamycin carries an exceptionally high risk of destroying the gut microbiome.
You are referring to the risk of C. diff.
Yes, Clostridioides difficile. Your gut is usually full of commensal bacteria that keep dangerous pathogens in check. Clindamycin acts like a nuclear bomb in the gastrointestinal tract, wiping out the good flora but leaving behind C. diff spores.
Which are highly resistant.
Extremely. And those spores then germinate and take over the vacant ecological niche. This leads to a potentially life-threatening intestinal infection. Escalating to a dual antibiotic specialist-level protocol on day 4 simply because a patient reports intense subjective pain is a massive overuse of our most critical pharmacological tools.
That's an interesting point, though I would frame it very differently. The use of clindamycin and cefixime is explicitly reserved for recurrent or resistant cases.
But we're seeing it prescribed constantly in urgent care.
Because we are talking about acute on chronic sinusitis. These are patients whose sinus tissues have literally remodeled and scarred from repeated, unresolved infections. The blood flow to those scarred tissues is exceptionally poor.
Which makes it hard for systemic antibiotics to reach the infection site, I know.
Exactly. The bacteria become entrenched in deep, oxygen-deprived mucosal pockets, creating a perfect breeding ground for anaerobes. A standard Z-pack or a few days of watchful waiting isn't going to clear an entrenched anaerobic infection behind a wall of scar tissue.
Still, the risks.
The guidelines are empowering urgent care providers to actually cure the underlying structural infection rather than just applying a Band-Aid and setting the patient into a cycle of chronic misery.
But if we agree that a major component of the patient's agony is neuroinflammation, the chemical burning of those olfactory neurons we discussed earlier, then if dual antibiotics are potentially too aggressive of a first step, the natural alternative is to directly manage that severe inflammation.
What do you suggest?
This presents a much safer path.
Are you talking about systemic steroids?
Yes, I am. Patients frequently request, and providers should seriously consider, steroid-only treatments for short courses, like 5 days or less.
I completely disagree with that.
Hear me out. A short-course oral steroid offers a way to profoundly reduce the devastating inflammation driving the nerve pain without contributing 1 iota to antibiotic resistance.
But it would cost.
Well, how does it work? Glucocorticoids tell the body to stop producing those inflammatory cytokines. You calm the storm, you reduce the swelling of the osteometal complex, the tiny drainage pathways of the sinuses, and once those pathways open, the sinuses drain naturally.
Assuming it's not blocked by polyps or severe scarring.
Sure, but often the body's own mechanical clearance resolves the issue without ever exposing the gut microbiome to something as harsh as clindamycin. This is especially effective when there is an overlap with allergies or asthma.
I have to strongly reject that approach. And the 2026 source material explicitly warns against exactly what you are suggesting. Taking a steroid without an antibiotic when a high fever is present is incredibly risky. It is a physiological trap.
A trap how?
Because, yes, the steroid might temporarily suppress the inflammation and stop the nerve pain. But let's look at how it achieves that. Corticosteroids inhibit the migration of leukocytes.
The white blood cells?
Right, your macrophages and neutrophils. It stops them from traveling to the site of the infection. They literally suppress the active immune response. Additionally, systemic steroids cause significant hepatic gluconeogenesis. They spike your blood sugar.
They do cause temporary glucose fluctuations, yes. That's a known side effect.
So consider the physiological environment you just created. You have a patient with a potentially high bacterial load sitting millimeters from their brain. You prescribe a steroid, which chemically disarms their white blood cells, while simultaneously feeding the bacteria with spiked glucose.
You're assuming a high bacterial load, though.
It allows those merely irritated smell cells to become truly, deeply infected. You are turning off the fire alarm and disabling the sprinkler system right when the danger zone is under attack. It is the absolute worst thing you can do during an active, fever-producing infection.
I understand the physiological risk of immune suppression, but we return to the core problem of assumption. You are assuming a high aggressive bacterial load is present in every patient who walks in with a fever and a severe headache on day 4.
If there's purulent discharge and biphasic illness, it's a safe bet.
Is it? If the pathogen is viral, which the vast majority of sinus infections are, the antibiotic does absolutely nothing. A virus doesn't have a cell wall for amoxicillin to break down.
I know that.
In a viral case, the short-course steroid provides the critical relief the patient is seeking in urgent care without the gastrointestinal fallout. The danger zone you describe is protected by robust anatomical barriers, and true bacterial breaching of those barriers is exceptionally rare. Antibiotic overprescription, however, is a guaranteed daily occurrence under these accelerated guidelines.
Which brings us back to why the 2026 urgent care triage protocols evolved in the first place. The shift reflects a hard-won clinical understanding that acute on chronic sinusitis does not behave like a standard viral cold.
It's certainly more severe, yes.
The sealed box of the frontal sinus requires us to listen to the body's systemic alarms. By utilizing symptom progression specifically, the undeniable shift from a localized forehead ache to a systemic fever, chills, and a diffuse whole head pain, providers are equipped to deploy necessary targeted antibiotics.
Targeted or just broad-spectrum escalation?
Whether it is using the clavulanate in high-dose augmentin to overcome beta-lactamase resistance, or deploying Doxycycline to leverage its dual antibacterial and anti-inflammatory benefits, early intervention at day 3 or 4 prevents the devastating consequences of severe neuroinflammation and orbital complications. Patient safety in the face of recurrent, entrenched infection simply has to take precedence over rigid adherence to an arbitrary 10-day waiting period.
And my position remains that while frontal sinus pain is exceptionally severe, we must trust the biology. The agony patients experience is fundamentally driven by trigeminal olfactory crosstalk.
The nerve misfire.
Right. It is a localized chemical irritation of the olfactory nerves that the brain misinterprets as a deeper whole head infection, rushing past the traditional 10-day waiting period based on subjective distress and fever, which again is just a natural hypothalamus-driven cytokine response, risks massive overtreatment.
But I just don't see it as overtreatment when the risks are that high.
But normalizing the use of specialist-level interventions like the Clindamycin cefacine plus strategy in standard urgent care settings accelerates antibiotic resistance. It exposes patients to severe gastrointestinal risks, like C. diff, for what is often a profound but ultimately self-limiting inflammatory event.
Well, despite our differing frameworks on the pharmacology, it is important to highlight where the 2026 guidelines force a clear consensus between us. We both acknowledge that traditional laboratory cultures, whether that is a surface throat swab or a delayed blood draw, have no practical place in the immediate triage of urgent care sinus treatment.
I agree entirely. They are simply too localized to the surface, or too slow to be useful.
Absolutely. And we also completely converge on the true emergency red flags. Regardless of whether it is day 4 or day 14, if that diffuse headache is suddenly accompanied by a stiff neck,
meaning an inability to physically touch the chin to the chest.
right, or photophobia, which is extreme eye pain when looking at light, or any altered mental state like sudden confusion or slurred speech.
Oh, definitely. Then the debate over urgent care antibiotics is completely over because that patient requires immediate emergency room escalation.
Exactly. Those are the signs of meningitis or true neurological involvement.
Precisely. Those are the measurable clinical signs of a breached barrier, far beyond mere nerve irritation.
This discussion really captures the intricate balance modern medicine must strike. It is a constant tightrope walk between managing genuine patient agony in real time and practicing responsible antibiotic stewardship to protect our long-term pharmaceutical arsenal.
It is a profound challenge. I mean, the subjective experience of pain is very real and terrifying to the patient sitting in the exam room, but the long-term consequences of our pharmacological choices affect the entire healthcare ecosystem.
We highly suggest that you look deeper into the 2026 MIPS quality measures and the IDSA guidelines found in our source material. There is a wealth of clinical pathways there to explore so you can form your own conclusion on the best way forward in urgent care triage.
There is a vast amount of fascinating biological mechanism to uncover in those texts, especially regarding how our olfactory and trigeminal nerves process inflammation.
Ultimately, until we invent a way to see directly through the bone, the human skull will remain a sealed box. And the question remains, when the alarms are sounding from inside the dark, how long do you wait before you act?